Okay, we're going to talk about duodenal stenting for malignant gastric outlet obstructions. But we're going to concentrate on endoscopic duodenal stenting, and we're going to talk about scope, what accessories we should use, the question of associated biliary obstruction, and importantly, stent positioning. Now, with regards to the endoscope that we use for this, it depends where the stricture is sited. If the stricture is in the pylorus or down to D2, then we would almost always use a forward-viewing therapeutic gastroscope. If the stricture is further round in D3 or D4, certainly in our practice we would often use the side-viewing duodenoscope, which can give you better angulation and a view through the stricture. Accessories, there are two things you want to do before stent placement. Number one, get a wire nicely down into the lower part of the distal duodenum or the small bowel, and the second thing is you want to define the length of the stricture. So the combination that we used for that is a long, usually 450 centimetre, 0.035 inch guide wire, and an ERCP, if you like, biliary extraction balloon. One of the larger ones, 12 to 15 or 12 to 18 millimetre diameter, and that allows you, let's say the endoscope is here, it allows you to blow the balloon up with the wire nicely down, and draw the balloon back whilst injecting contrast, and you'll see this on the videos that we've got to accompany this, and then you inject contrast and quite nicely see normal non-strictured duodenum being delineated. Okay, you can then leave that wire in place and remove the balloon and then stent over the wire, which we'll come on to. The important question of associated biliary strictures. We're talking about malignant obstruction. Two common primaries for this include a cancer in the head of the pancreas. That often causes obstruction of the second part of the duodenum, and gallbladder or mid-duct or hilar cholangiocarcinoma. That normally is associated with obstruction in the duodenal bulb or the first part of the duodenum. Okay. If you have biliary obstruction, and particularly if the patient is jaundiced, then you should drain or stent that biliary obstruction before stenting the duodenum. Now, sometimes one can do it all at the same time, placing an endoscopic biliary stent at ERCP and at the same time then following that with a duodenal stent, but of course that is usually impossible for the obvious reason that you can't cannulate the papilla because you've got the duodenal stricture. And so other approaches to managing the biliary stricture include, well, endoscopic ultrasound directed biliary access, which is also a topic of this meeting, or a percutaneous transhepatic drain and stenting. Okay. Crucially, stent positioning. Once you've got a wire through the stricture, anybody can place a stent. I exaggerate, but should be straightforward to place a stent across the stricture. But we need to consider very carefully the distal and the proximal end of the duodenal stent. And this is a really tricky one because of this. If you have a stricture involving D2 and you put in a biliary stent, you might get it deploying beautifully here. I might just clear the, draw this again. So your stricture is here, you place the duodenal stent, you worry about the lower end, which is deployed here, and the proximal end is here. Now, the problem with that can often be that as that stent beds in, it tends to straighten out. And in straightening out, the risk is that the stent then flat valves against the lateral wall of D1. And so you then have a stent that is nicely across the stricture, which does not work because of flat valving, either proximally or sometimes distally against D3. And so a really important question that you need to decide upon before you insert your stent is where the proximal flange is going to be. And certainly, if a stricture is round in D3, then we would often deploy the proximal end in D1, D2 if that's uninvolved. But if the stricture involves D1 or D2, it is often preferable to bring that stent out into the pre-pyloric area and deploy short of the pylorus, and that provides the best opportunity of good relief of duodenal obstruction. But I would just say that patients with duodenal obstruction are usually dependent upon a liquid or a semi-solid diet. It is quite unusual to be able to return to an entirely normal diet.